Hi and welcome back to another video of Medic Notes. This video is on urinary tract infections. These may be divided into those affecting the kidney, pyelonephritis, and those affecting the bladder, cystitis. UTIs are more common in women, and the majority of women will have had a UTI at some time during their life. The risk factors are pregnancy, urinary tract malformations, urinary tract obstruction, calculi, prostatic obstruction, bladder diverticulum, spinal injury, trauma, urinary tract tumor, diabetes mellitus, and immunosuppression. First, for acute pyelonephritis, infection of the kidney by pyogenic organisms. Its pathogenesis is due to hematogenous spread, retrograde uretic spread, and the organisms include E. coli, Proteus, Enterobacter, Klebsiella, Pseudomonas, and fecal streptococci. Clinical features of acute pyelonephritis are malaise, fever, dysuria, urgency of micturition, pain and tenderness in the loin. Complications include renal papillary necrosis, pyonephrosis, and perinephric abscess. Whereas for chronic pyelonephritis, it occurs in association with vesicoureteric reflux, either due to congenital lesions or occurring in early life, and obstruction developing during childhood. Vesicoureteric reflux is associated with abnormal entry of the ureter into the bladder. Reflux of urine into the kidney during micturition raises intrapelvic and intracalyceal pressure. The presence of infection accelerates scarring due to reflux. End result is scarring of the kidney with interstitial fibrosis, atrophic and dilated tubules containing eosinophilic casts, giving the appearance of thyroidization of the kidney. Unless vesicoureteric reflux is successfully corrected, the condition may proceed to chronic renal failure and need for dialysis and transplantation. Next, for cystitis. Inflammation of the bladder is a common occurrence as part of a urinary tract infection. Causative organism usually derived from patient's fecal flora, such as E. coli, Proteus and Klebsiella. Mostly due to retrograde spread of the organisms along urethra. 20 to 30% of women will have bacterial cystitis at some time during their lives. Predisposing factors in females are short urethra, urethral trauma during sexual intercourse, and pregnancy. Instrumentation of the urinary tract in both sexes increases both the incidence and variety of infecting organisms. Other organisms include Candida in immunosuppressed patients or patients on prolonged antibiotic therapy. Tuberculous cystitis always reflects tuberculosis elsewhere in the urinary tract. Irradiation, trauma due to instrumentation and drugs like cyclophosphamide, may cause cystitis, which is often sterile. The clinical features of cystitis are frequency, lower abdominal pain, dysuria, occasionally hematuria, general malaise and pyrexia in some patients. Another condition seen in UTIs is sterile pyuria. Pus cells are apparent on microscopy, but there is no growth on culture. Causes include inadequately treated UTI, tuberculosis, tumor, stone, prostatitis, polycystic kidneys, appendicitis, where the appendix adheres to and irritates the bladder, diverticulitis, adheres to bladder, and analgesic abuse. Urinary tract TB. This has shown a decline in the past 30 years but remains a problem in the Third World and in immigrant populations in the UK. Features include, always secondary to TB elsewhere. Urinary tract is involved by hematogenous spread. Kidney is affected most frequently. Lower urinary tract secondarily infected by descending infection, giving rise to cystitis or infection of the epididymis or seminal vesicles. For its clinical features, it is often silent. Repeated UTIs with frequency, dysuria, hematuria. Occasionally dull loin pain, weight loss, fever, night sweats. Symptoms of uremia, epididymitis, and scrotal sinuses. That's all for this video. Thank you.